Hello, everybody. My name is Annika and I'm currently working in Lucerne, Switzerland as an intensivist. And our today's topic is intra-abdominal pressure, when to measure and when to treat. These are my disclosures. And now we move to the topic. You see here several studies published during the last decade, and you see that intra-abdominal hypertension occurs often in almost half of the patients admitted to the ICUs. Most of the cases, it is grade 1, so mild intra-abdominal hypertension, and prevalence decreases linearly towards the higher severity degrees of intra-abdominal hypertension. But importantly, you see that very high pressures were documented in all of these studies, including more or less concomitant patients. And here you see the prevalence once again, decreasing towards the higher degree of severity, here presented as prevalence in total from ICU patients. And at the same time, you see increasing mortality towards the higher degree of severity. And in the most severe case of intra-abdominal hypertension, where pressure above 20 is associated with new or worsening organ dysfunction. And you see that it occurs, although not very often, but it occurs, but the mortality is very high in this group of patients. And now we look, when does this intra-abdominal hypertension occur or develop in the ICU? And you see that in most of the cases, it is already there on admission day, but 1/3 of the cases develop also later during the ICU stay. And if you look at the grades at admission and any time during ICU stay, then shift towards higher severity of intra-abdominal hypertension occurs in patients developing intra-abdominal hypertension during the ICU stay, not present at the beginning. If we look at the risk factors, then several of them have been identified in several studies. This systematic review is already quite some time ago, and it included mainly studies on selected patient groups, whereas these recent studies are on concomitant, on consecutive ICU patients. Sorry. And we see risk factors as obesity, identified as defined as different cutoff with body mass index, severity of illness, some abdominal signs and symptoms, mechanical ventilation or certain level of end expiratory pressure, positive end expiratory pressure, sepsis or abdominal surgery, and also fluid balance. Importantly and interestingly, fluid balance was not identified as a risk factor at admission in our recent study, but it was a risk factor to develop intra-abdominal hypertension during the ICU stay later. Now, how to use this information about risk factors in clinical practice? In whom should we then measure intra-abdominal pressure? So we have constructed a decision tree to detect patients with intra-abdominal hypertension based on our IROA study data. And we see that in patients with mechanical ventilation with PEEP 7 or higher, intra-abdominal hypertension occurs often. So it makes sense to measure in these patients. In the two other groups, if Apache score is 18 or higher, intra-abdominal hypertension occurs also often, so these would also belong to the measurements. And if abdominal distension is there for these two groups with spontaneous breathing or mechanical ventilation with low PEEP, then it makes sense to measure intra-abdominal pressure. If we applied now this algorithm to our real IROA study data, where we actually measured intra-abdominal pressure in all patients, then we saw that we would have hypothetically measured in 62% of patients and missed 36 cases of intra-abdominal hypertension. Among them, 19 intra-abdominal hypertension grade 2 or higher. This is another option to aim detecting grade 2 or higher, not all the patients with grade 1. And there we see that adding severity of illness to these two groups of spontaneous breathing or mechanical ventilation with low PEEP does not justify measurements, whereas adding abdominal distension probably does. And applying such an algorithm to our real patients, we would have measured intra-abdominal pressure in 44% of patients, and grade 2 would have been undetected in 16 patients. But now we also need to look towards the later development in the ICU, not only risk factors on non-admission. And we already mentioned that cumulative fluid balance was a risk factor to develop intra-abdominal hypertension later in the ICU. And we see that in all our 3 groups, as presented also in previous slides, we see that in all these groups, prevalence of intra-abdominal hypertension is high when patients reach a cumulative fluid balance of 4 liters. So this probably justifies measurement. Another option would be to create a risk calculator and enter all the values for individual patient and get the risk of intra-abdominal hypertension for this particular patient. However, there still would be a need to define the optimal cutoff to start measurements, which risk justifies measurements. Now, anyway, if we measured and detected intra-abdominal hypertension, then we need to know, should we do something about it? We should always do some interventions that would help also reducing intra-abdominal hypertension, and these shouldn't be forgotten. However, if intra-abdominal pressure increases and the risk of abdominal compartment syndrome is high, then we also need to consider more invasive interventions, and always at the same time consider risks and side effects. And if ACS is then present, then interventions are clearly needed and necessary. We always should think which is more relevant, intra-abdominal hypertension impairing outcome or treatment of intra-abdominal hypertension possibly impairing outcome. And to help to reach these decisions, there is a graph from recent publication in critical care where we see that we should consider cause of intra-abdominal hypertension, but also patient characteristics. We didn't mention obese versus not, because we don't know exactly whether there should be different cutoffs for obese patients. Disease characteristics, is the problem solved or not? The organ dysfunction characteristics, progression, dynamics, but also concomitant macro and microcirculation. And about intra-abdominal pressure, not only magnitude or the level and dynamics, but also duration of intra-abdominal hypertension is relevant. Anyway, any specific value of intra-abdominal pressure alone is insufficient to justify treatment decisions. And take-home messages are intra-abdominal pressure measurement should be based on initial risk assessment and daily clinical reassessment. Any specific value is insufficient to take a management decision. We should consider patient characteristics and disease dynamics, progression and duration of intra-abdominal hypertension, risk of consequences of intra-abdominal hypertension versus risk of treatment of intra-abdominal hypertension. However, abdominal compartment syndrome needs to be prevented or if occurred, immediately treated. Thank you very much for your attention.